Our loved ones know where our buttons are, and when things are heightened, they take a sledgehammer to that button, and it's like, oh, sometimes I feel really bad what I ask parents to do. You know what? We just got to get it right 1/3 of the time. That's what they talk about. We don't have to be perfect. We just doing our best, and we can always recover. We can go back and say, hey, I didn't do that the way I wanted to. Can we try over?
Hello and welcome. We're so glad you're tuning into the Taking Good Care show. I'm Dr. Andrew Wong, based in Toronto, Canada.
And I'm Dr. David St. Arnaud, based in Edmonton, Canada. We're two practicing psychologists with over a decade of experience each, working in a variety of settings and supporting diverse populations.
Thanks for joining us. We hope you enjoyed today's episode. While we're both practicing psychologists, our podcast is intended purely for educational and entertainment purposes. It's not a substitute for professional mental health care or treatment. If you're in need of support, we strongly encourage you to reach out to a licensed mental health professional in your area. Good morning, everyone. Welcome to another episode of Taking Good Care. Dave and I have not seen each other for a couple of weeks now. So actually, I feel like I'm a little bit rusty today going back into podcast recording, but I'm really excited. You know, when I thought about it, we haven't done this in the last couple of Fridays. So it's like, oh yes, we get to record again. And on top of that, we have a guest with us. And I love this, as I said in our traumatic brain injury episode, just getting people on who we know who do great work. They're humble about it. You know, they're not in the spotlight for all the work that they do with families and children and individuals who are struggling. And we have another person on today, another psychologist who I think does some really amazing work in the community and in community mental health. So we have Dr. Mark Nicoll here. Dr. Nicoll is a registered psychologist in Edmonton, Alberta. He has worked with children, youth, and families in the public health system since 2004. He is an adjunct professor in the Department of Psychiatry at the University of Alberta, as well as a therapy supervisor for child and adolescent psychiatry subspecialty residents. Mark is an approved supervisor for mentalization-based treatment for adolescents, which is a therapy model that was first developed to treat borderline personality disorder and has now been applied to other diagnoses such as eating disorders and family therapy. Mark has asked us that we emphasize that his comments and opinions are his own, and he does not speak on behalf of his employer or any other organizations. And just of note too, today we will be speaking about mentalization, we'll be speaking about borderline personality disorder, and also suicide ideation, self-harm, suicide risk. So Dave and I and Mark want to just throw out there that if any part of this conversation is uncomfortable, if it's unsettling, or if it's triggering at all, we do please ask you to seek professional help in your community and where you are. So welcome, Dr. Mark Nicoll. And just some self-disclosure here, Mark was my supervisor when I was out in Edmonton. So we were just chatting. We go way back. I would say it was probably 2011, somewhere in there when we first met. I was seeking out practicum with children and adolescents because U of A, you know, we had some of those rotations, but I was given a lot of the adult ones and I wanted more experience with practicing with children. And Mark was so gracious. I can't even remember who gave me your contact. Somebody gave me your contact and you were so friendly. You were so gracious and taking me in under your wings and showing me the clinic there. I still have mental pictures of that clinic. It was a really nice clinic and we ran groups. I saw some individuals there. It was a training program because there was the one-way mirror there. And this was in community mental health. Like this was, I think, part of Alberta Health Services.
It was. That's a ways back. And I don't remember a lot of the details, but I remember the vibe, which was very good. And you too were also friendly and welcoming and warm, and you still are. So it's awesome to see what you've done with this podcast. And this is my podcast debut. So I'm not used to this. So you and Dave are going to have to help organize my thoughts.
Not a problem. I think we'll all share the load and help each other organize our thoughts. That's kind of how we do things on this podcast.
So Mark, you've moved on from that clinic when I was there. But you've stayed with community mental health in Alberta and Edmonton.
Yes. Yeah.
And interestingly, you and Dave know of each other. You've heard each other's names, but
Right.
have never actually spoken to each other. So
No.
again, I'm glad that I am this conduit from Ontario,
Yeah.
from Toronto, who is making this connection for the two of you to hopefully collaborate in the future.
That's right. We've got some shared interests and it'll be good.
Yeah, I mean, I'm happy because this is a side benefit of this podcast is I get to meet really cool people that are doing great work. And if Andrew thinks they're okay, then I'm happy to kind
All
of
right.
start to get a
Yes.
connection with them. Yeah. So
Yeah.
And the fact that Mark didn't ignore my calls and emails, hopefully that means,
Heck
I was
no.
a
Heck
I was a good
no.
student at the time.
No, it was, yeah, it's so good to see that the stuff you guys are doing. It makes my heart warm. There we go.
Awesome. That's what Dave says. That's cool. That's cool. So, in terms of your work, Mark, I'm wondering if you can let our listeners know what you're doing right now in terms of community mental health in Edmonton, even perhaps the types of referrals that you get. And we're in private practice, Dave and I, and private practices seem to be just proliferating all over the place. But you stayed within community mental health, and I'd love to know your take on public healthcare when it comes to psychology and what you do.
Right now, my role is as a clinical supervisor, so I don't do a lot of direct clinical work. I'm primarily supervising mental health therapists in the community mental health clinics who work with children, youth, and families with ages, between 5 and 17. And in Edmonton, families can self-refer to see one of our therapists. They can be referred by a school, they can be referred by their family doctor, but parents and caregivers, guardians can call in and contact someone to get booked with a therapist. And so those young people and their caregivers come in and then they get supported through our mental health therapists, and I support those therapists, and we work together and also do groups for parents and for young people. So yeah, I've been working in the public health system, like I said, for 20 years, and it's been very good for me. I've just enjoyed it. Like, we get to work with all sorts of different families with all sorts of different presenting issues. And I really like working with children and youth because I always get to tell parents that, development is on our side. It's an optimistic time for me that their brain isn't going to stop developing until they're 25. And if we're seeing them at 8, 10, whatever it is, 16, things are going to change. And so that I like that optimism and being able to communicate that to families. And yeah, it's a very interesting, sometimes stressful environment, but lots of meaning in our work. Whether you're in private practice or in public health care, we're doing important work and helping families with important things. So I really like that.
So, Mark, if I'm following, do the mental health therapists that you're working with, that you're supervising, are they across the community at different like primary care networks and things like that?
Okay. They're in community health clinics. I think we have 8 in the Edmonton zone.
Okay.
Yeah.
And there isn't like a clinic or a hub where all of them are working from running these groups. They're kind of spread out.
They can be spread out. A lot of our groups are virtual.
Okay.
And some are in different clinics. They can be in different points in time.
So, Mark, your work now, I guess more specifically, is working with adolescents and youth who may be displaying characteristics or traits of borderline personality disorder. Is that correct?
Yeah, that's a subset of them. Yeah, no, we're generalist clinics, but the prevalence that the research tells us is about 10% in like a clinic like ours. So about 10% of our clients would sort of fit that pattern, have that set of symptoms.
And I find this really interesting topic because we often associate borderline personality disorder with adults, and not too many will associate BPD with teens or youth. So even off air when we were chatting, it's like there's a big misconception that you can't be diagnosed with borderline personality disorder before adulthood, where in fact you can as a teenager.
Yeah, you're right. You still run into people sort of saying you can't make that diagnosis, and you absolutely can. And it's been since probably DSM-3, for sure, since DSM-4. that diagnostic and statistical manual that we all go to for diagnoses for mental health disorders.
Well, and again, kind of off air a little bit that we were discussing how today would go. Like we could keep going down this path, and I think there's a bit of a teaser with BPD, so we will get
Right,
to it. But
right.
I think I want to hear more about like the treatment or the approach that you might use in terms of mentalizing. This is actually a treatment approach that I had no formal training during my graduate training, and I've learned
Yeah,
about since, but I don't have any formal supervision or training in this. So I'm
right.
very curious, and I followed up on some of the links that you sent to learn more about it. So even for the general listeners, they might not have heard this before in terms of mentalizing.
No. Where did you first hear it, Dave? I'm curious. How
Oh,
did you hear about it?
actually on another podcast, I was listening to a psychiatry
Oh,
podcast, and I think it's a lot bigger in UK and in Europe. So the guest
yeah.
was speaking about it from there, and yeah, it piqued my interest.
Gotcha. Gotcha. Okay. Yeah. So mentalizing, the formal name is mentalization-based treatment. And it comes out of the UK, developed by a psychologist, Dr. Peter Fonagy, and then Dr. Anthony Bateman is sort of the co-creator of MBT. They both came up with this concept. Now, they didn't come up with the concept because they would be the first two that would say, you know what, this has been a term that's been around for a long time. And they sort of dusted it off and then made it into a therapy. And one of the things one of the quotes from Peter Fonagy is he says, you know what, this is the least novel therapy imaginable. They haven't created anything different. They've named it, but they've made it into a therapy. So the first thing that we should probably do is just try and figure out what the heck is mentalizing. What does it mean? And so there's multiple definitions that I like to offer. There's the formal one, which my brain starts to tune out even as I say it. But that's where mentalizing is the ability to reflect on internal mental states and basically how they relate to someone's behavior. And so how do you make that into a practical definition? That's basically saying it's an ability to reflect on people's thoughts and feelings and how those thoughts and feelings relate to their actions. So it's also something you can do to yourself. So I can mentalize you guys. And I always like to, one of the ways I think about it is like a comic book. So if we're all on a Zoom call right now, we can see our pictures. So if I'm trying to mentalize Dave or Andrew, I'm putting those comic book thought bubbles above your head. And it's like, what's Dave feeling right now? What's he thinking right now? And I'm just guessing. And I get it wrong at work and at home tons of times. But an informal term I like is mind guessing. Instead of mind reading, mentalizing is like mind guessing. And so trying to guess what's in someone's mind. And we all do this. And we do it naturally, whether you're a therapist, a psychologist, or a parent, or anybody, a spouse, we all do it naturally. When we're therapists, we all do it in a more intentional way, where we slow it down and sort of, I'm really curious about what this client is thinking and feeling. I'm going to ask them, I'm going to try and guess. And so mind guessing is one way I look at it. Peter Fonagy talks about holding minds in mind. So I'm trying to hold your mind in my mind, represent you. Probably the final way that I talk about it is using a mentalizing phone. If I use a mentalizing phone, let's say I've got my camera, I'm in session, and I wouldn't be pointing my camera at somebody in session, but if I've got a mentalizing phone, I'm pointing this at Andrew, and Andrew's in my lens. And now I'm mentalizing Andrew. What's he thinking? What's he feeling? Wonder how that what he was doing when he's telling me this story. How was he thinking and feeling? So that's me focusing my mentalizing on Andrew. The nice thing about mentalizing is I can flip and do a selfie. Now I'm in my own screen, and I'm saying, what's going on for me right now? Maybe I'm excited. Maybe I'm curious. Maybe I'm noticing that I'm tired, or I might be frustrated because, I'm not helping Andrew the way I'd like to be helping him. And so that's me being aware of my own mentalizing. So you can do it to someone else. It's something that you're trying to mentalize someone else, or you can mentalize yourself. And it's sort of like a muscle that develops through our attachment relationships with our parents and our caregivers over many interactions. You got a little baby who's crying, and a parent comes in and they're trying to figure out, are they hungry? Do they need to be changed? And they piece together clues. And then baby just has this experience of something is horribly wrong. I don't even know what it is. And now you have mom come in and sort of say, oh, you got a poopy diaper. No wonder you're upset. And they do that motherese, and they sort of repackage this chaotic bundle of distress and give it back to that infant and say, you had a poopy diaper and we're going to change it. We got this covered, and we're going to be okay. And so thousands of those interactions help develop that mentalizing muscle. And in therapy, that's something that we do with our clients, where they come in with this big bundle of distress. And I know with our young people, it's often like, I was just so upset. I didn't know what to do. Now we start to tease apart the strands of this ball of yarn and sort of get a story out of it, and then create that story and give that back to the client. Am I making sense?
A lot of sense. And I was actually going to ask, that muscle that you talked about that you develop through mentalizing, to me, it like that phone analogy was great. And it sounded like it's almost like being able to take social perspectives. Is that on the somewhat
Yeah.
of the right track?
Yeah. What I
Okay.
say in my presentations is that mentalizing is like an umbrella term. So mindfulness is a type of mentalizing. Mindfulness is often focusing on yourself and your own thoughts and feelings, noticing things, trying to be curious, not judgmental. Empathy is mentalizing someone else's feelings and trying to put yourself in their shoes. There's that theory of mind, perspective taking. So when people hear about mentalizing, they're like, well, isn't it that? Isn't it that? Yep, it is. And it just has this, it's named something that sort of encompasses those concepts, and then has built it into a therapy.
As you were talking about the definition, it just brought me way back. I don't know how old I was, but I think I was probably going to be a psychologist before I knew I was going to be a psychologist
Yeah.
because I had this fantasy that if I could have this TV screen, because we didn't have phones back then, we just had TVs, right?
Right.
And if the TV screen could show what people were thinking in their head, like if I could just see that screen, then I would be able to better navigate like the world.
Yeah.
So it sounds like this is, we're mentalizing in some way is like taking that perspective of the other person, being able to see what they're thinking and feeling and behaving.
Yes.
And if I'm following you, some people struggle with that. Like this would be something that they would need
Absolutely.
help with in therapy.
Absolutely. And we all struggle with it,
Yeah.
just at different proportions.
Mhm.
So it's this idea that they also, it sort of comes out of the attachment literature and sort of philosophy. That's where mentalization has sort of grown up from, developed from. And they talk about when your attachment system is stimulated, mentalization becomes harder. So when you're in an intense relationship, when emotions are high, our ability to mentalize goes down. And that's for everybody. And some people get affected by that more than others. I talk about, there's Dan Siegel's flip your lid analogy. I don't know if you guys have heard of that. There's a really good video on it about the upstairs brain and the downstairs brain. But this idea, we all flip our lids. And when you flip your lid, you're not mentalizing very well. So yeah, it becomes hard. It's something that we lose frequently. But the idea of mentalization-based treatment is, our goal is to try and is to keep it happening when we're with our clients. And if we lose it, we try and get it back. I might be the one as the therapist who loses it. I might realize, and I do this in sessions. I'm like, I just lost my train of thought. And I might be saying something and I'm like, oh, I'm not sure where I'm going with this. And that's a sign, that's a clue to me. I'm not mentalizing super well. What's going on? And they call this a relational process therapy. So it's not a skill, it's not an explicit skill therapy where we sit down and we teach people different skills. It is more of an implicit skill. And I liken it to if the goal is to learn how to ride a bike, I contrast mentalization-based treatment with dialectical behavior therapy. That's another therapy that is often used for borderline personality disorder. And I've done it myself and I use it in my life and I actually like it. I resonate with MBT more, I think because of my mindset. My mindset's not very organized. So sometimes I find DBT hard because there's a lot of skills in DBT and they're helpful, but I sometimes lose track of them. So coming back to the bike analogy, let's say if learning to ride a bike is like learning how to have healthy relationships with yourself and with other people, DBT says, you know what, we've broken down bike riding into about 40 different skills. And you're gonna come to group or come to my sessions, and we're gonna look at these skills, and I'm gonna talk about which ones you should try and learn in order to ride that bike. And so that's how a DBT session can be structured. My analogy is for mentalization. Me as a therapist, let's say I'm pretty good at riding a bike. I say, well, let's get on this tandem bike. And I know my client's not as good at it. I'm going to keep us balanced as good as we can. It's going to be wobbly, but we're going to go ride this bike around the neighborhood. And that means, and then we're going to learn by doing. And that doing is sort of unpacking things in sessions, trying to figure out what's important to this person, trying to help them pay attention to their own thoughts and feelings, not with an emphasis on changing it, but being really curious and just noticing things. And that gets into the mentalizing stance, which I can talk about, but I'm also mindful I don't want to ramble too much.
I was gonna say, Mark, like when you talk about the like it's less skill focused. I'm just wondering how clients or even caregivers of the teens and adolescents who you work with, how they sort of feel about that. Because when I have children or parents, I guess, who come in and caregivers who come in, they're looking for skills. Like they come to therapy thinking, okay, I'm gonna gain like this whole set of skills and we're gonna apply them when we leave. And so when you explain mentalization to them in this way,
Yeah.
what's the reaction that you get sometimes? Because I can see some people going, wait, what? We're just gonna talk about our week, our day, our
Yeah.
experience?
What's the reaction? It's a great question. And I also I've learned over the years to distinguish between, because our system, I find our therapeutic bubble, if you will, that I think we're all sort of in, is a very skill-focused bubble. That if you're
Yes.
not teaching skills, you're not doing therapy.
Yes.
And it's just pervasive. So how I view mentalization is I say it's an implicit skill as opposed to an explicit skill. Explicit skills are deep breathing, sitting here practicing mindfulness, how do you assert yourself and all those kinds of things. Great skills. An implicit skill is something you sort of just learn by doing and then you realize you're doing it. So I don't really explain it to this degree, to be honest, because families don't ask, but I do sort of say, this is what I do. And what's important to me is for us to sit down and have an important conversation that's relevant and important to you, the young person, and mom, it feels like, or mom and dad, it feels like it's important to you as well. So we are going to still have goals, but that is a challenging piece of mentalization, which is how the heck do I do it? Because you have to build a framework, and I've been learning about it for the last 10 years. And so when I teach it to other people, they also struggle with it, where sometimes, yeah, it feels like I'm not doing anything. But if I ask a young person at the end of and this is one of that I will actually do, is taking from Scott Miller's work, I like to sort of say, let's take the temperature of our session today. And, most of us sort of say, did anything stand out as helpful or important or relevant to you? We often just stop at the helpful. I like to go to what stood out as important or relevant to you. And if we get something there from a young person that says, well, I think this was helpful or relevant and it was important, then that's the litmus test I have. That's progress, that we found something important to talk about. And not just the young person. I would say, I want to have a bit of a vote too. Because if I'm just sitting there listening to them tell me a long story and I'm an audience, That's not mentalization.
Mhm. Yeah.
Because I will interrupt. Mentalization therapists, we try to be polite interrupters because sometimes people that you might notice a client's not mentalizing. There's some subtle signs, and I'm going to try and interrupt that.
Mm-hmm.
And I'm not going to tell them you're not mentalizing right now, but it's just there's a lot of things that we can get into. But sometimes, yeah, parents might sort of say, use those skills that Mark's teaching you, and they might sort of say, "What? He's not teaching me anything. We just talk."
I am
That's
so
it.
I'm so glad you're bringing this up because this is an internal struggle for myself too. Sometimes, even just the other day, I had a parent reach out to me and say, I want to know what your treatment plan is for my child, and I want to know what skills
Yeah,
you're teaching
yeah,
them. Or I've even had adults where, the spouse is saying, "What are you learning in therapy?" And I've been jealous at times with like DBT or some of these other approaches that, I've had people walk into my office with a binder of like, here are the skills that I'm working on. And I'm like, oh, that's
right.
so tangible, right? Like you can take that home with you. You can have that. If you're struggling, you can open the binder up and find the page that you need to figure out kind of what skill you need to be working on. Whereas a lot of the experiential therapies, and I think that's what I'm getting from you with mentalization, is it's happening in the office. You're learning by doing
Yeah,
rather than by talking about doing something. And you might not always have those like handouts that describe exactly what's happening,
right,
but it's
right.
a struggle to explain to other people. Like, well, I feel like I'm getting better, but I'm not sure what tools or skills I'm learning in my therapy.
Yeah, yeah. That's well put, Dave. I find losing my train of thought. See, this happens. This is like a session, you guys.
While you gather your thoughts, actually, Mark, I wanted to add to what Dave was saying. Like, I often tell clients or even parents, like, life and parenting is not so manualized. Right? If there's a
Yeah,
manual to parenting, like whoever created that manual that just gives you all the magic answers,
right.
like that'd be a magician, right? Like, they would be considered a magician. And I think in so many cases when I am working with caregivers and clients, it's being in that moment of like, okay, how do we problem solve? Right. It's not necessarily like I'm going to give you a three-step skill set to
Yeah,
say, okay, if you do these three steps, you're going to be fine. No, we have to look at the situation holistically and contextually to figure out how do we get through this situation.
yeah. And I think with MBT, yeah, it's there's those implicit skills, and we want if we're not getting where we want to be, we have to have some sort of measure. Then we got to do something different. And if someone comes in, I think it's also important to say, if someone comes in and they have a bunch of skills that they want to practice and it really feels right to them, no problem. That doesn't mean we're not gonna pay attention to skills. But the young people, and this is the point I was thinking, maybe it was you that was just asking, or no, I think it was Andrew, how do young people react to this? They actually react quite positively because they don't come in often saying, could you give me some worksheets so I can work on these? That is a
So true.
challenge that everybody struggles with. And DBT clinicians have to be really good at, at sort of facilitating that process. I happen to not be very good at it sometimes. And so I think that's why I resonate more with MBT. But I know therapists who are really good at those explicit skills and they validate the heck out of their clients. And in DBT, they say validation is what really helps the medicine go down, right? If you're not validating, you're not going very far. And if you're not thinking dialectically, sorry, and I'm bringing in those terms, but I know sometimes some therapists will listen to your podcast and some families and clients will listen. So I sometimes struggle with who's our audience right now, and I'll start throwing things out there. So I apologize.
I think you're mentalizing right now for the audience.
I thought about that actually. I have been trying to mentalize your audience since Andrew and I were talking about this. Like, who am I talking to? Am I going to be talking to a young person who's curious about this stuff, or a parent, or a potential client or a therapist? And it was
Everybody,
hard.
everybody.
Hello to all of you.
So, Mark, as we're talking about mentalization, I know you do a lot of work in this area with the borderline personality disorder
Yeah,
population, right? And
yeah.
I'm just wondering, as we marry the two together in your work, can you describe a little bit more about what borderline personality disorder is, and then how does mentalization apply to BPD?
Yeah. Before we go into that, Andrew, there's one thought on my mind, which, we're just touching on mentalization-based treatment right now, so I
For
know we're
sure.
not going to do it justice, but there's a colleague of mine and people have talked about this as well, says that, mentalizing a therapy session for MBT often has a conversational tone. It feels like a conversation, but it's an intentional conversation. And you think about when any of us go out for a coffee with a friend and you've been upset. I've had a couple of those where I'm sitting down with them, I'm telling them what's going on, and I know they're with me. And our friends often don't sort of say, well, have you thought about deep breathing? Have you thought about doing, as soon as they start talking about fixing things, it's like, oh, this isn't what I needed today. We walk away from those conversations with those good friends feeling understood and supported. And that's sort of a big part of an MBT conversation slash
Mhm.
session is it's like validation on steroids. That's a term I've used sometimes where it's just super focused on, I'm going to get as curious as I can about your experience and we're going to unpack some things. So that helpful conversation is a concept that I emphasize.
Well, and I want to just, before we move on too, to make sure that I'm clear about this. Like, my understanding is that we want to suspend judgment or like assumptions about people's behaviors in a lot of ways, and we want to get curious, like you're saying, and ask them about what is going on for them.
Absolutely.
And then you might also share what's going on for you in terms of, because I've had clients be like, well, what do you feel like? How do you see me right now? Or what do you think about this? And it's like, ooh, that can be kind of scary for a therapist who is not used to self-disclosure, right?
That's right. That's a great point, Dave. And that's part of the mentalizing stance. When you learn about this therapy, they talk about transparency and authenticity. So you want to be yourself. Now, it's not 100% transparency. I don't sit down and tell my clients that I just had a fight with my partner and I'm pretty tired today. But I will share more of my mind than normal, which is sort of like, if you want to know what I'm thinking, I will tell you that I'm a bit confused right now. I think I've lost the plot. Or I will say, I am a bit frustrated and I'll try and let me just sort of think on this. Why am I frustrated? So that's me role modeling being curious about my own mind. And
Mm-hmm.
so we are switching the focus. Sometimes it's the client's mind, sometimes it's my mind, but it's always for the benefit of the client.
Mhm.
And we are another part of this mentalizing stance is a not knowing stance, which is we are curious about as much as we can, and we aren't necessarily changing it right away. So for those therapists who are CBT cognitive behavioral therapists, there's sort of an instinct to challenge cognitive distortions right away.
Mm-hmm.
Mentalization does not jump to challenge right away. It's sort of
Mhm.
just really unpacks. So you were thinking this here, feeling that there, and okay, that makes sense to me. I think, yeah, when you're in that situation, it would make sense to feel that way. But I got lost on how that happened. So you just keep finding things to be curious about as long as it feels relevant and important.
So maybe I'll make the segue then to BPD, because some of the comments that I get are like, you probably don't like working with me, or you're probably tired of seeing me, or some of these comments that'll come at me in terms of like, you
Yeah,
you don't have to work with me anymore, right? Like, I won't
yeah,
put you through this anymore. And I'm like, hold on, where is this coming from? Because that is not where my mind
right,
is at or my feelings are at, right? And it's like, oh, let's get curious about that
right.
assumption about my mind or my, and I'm trying to make this like, because I don't work from a mentalizing, perspective, but it's like I think this is similar.
Oh, yes, 100%, Dave. And I think the other piece of what they say about mentalization is all good therapists are good mentalizers. Doesn't matter if you're doing MBT or not
Yeah.
intentionally.
Yeah.
I view it as and it's talked about this as a common factor. So whether you're doing narrative, CBT, emotion focused, all of those involve mentalizing yourself and others. And good therapists just have that skill. So people are doing it already. right? And it's just been named. Now, with borderline personality disorder, one of the things that MBT, the theory says about that is folks with BPD, diagnosed with BPD, struggle with mentalizing more. They struggle to mentalize themselves. And that comes, BPD can sort of be defined roughly as, struggling with your emotions, with relationships, and with your identity. And if people can always look at the specific criteria for it, but those things you're gonna struggle. Those are all struggles with mentalizing, right? Who am I? What do I feel? How do I feel? When do I feel it? I get overwhelmed by feelings. And that that's how MBT mentalization was connected with borderline personality disorder. It's an evidence-based treatment for BPD. And before I go on, I'll check in with you guys. Any thoughts or questions? Am I making sense?
Yeah, I'll just add that like we will have some links so that people can look up, more about this. Even with the mentalizing, there's some videos that if people are curious about, because we can't cover everything in this
Yeah.
podcast.
Yeah,
So
thanks.
Yeah.
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 I thought I would say, trying to define what's borderline personality disorder. And if someone, my first disclaimer, if you will, is there's a couple points I always like to make about diagnoses, mental health diagnoses. I came across a phrase years ago, I think it was from a narrative therapist that I read, and it was diagnoses are descriptions, not identities.
Mhm.
And that so resonates with me that we often get a lot of young people and a lot of adults too saying, I am depressed, I have BPD, and we're looking to figure out who we are, and so it becomes their identity. And what diagnoses actually are they are descriptions of sets of problems that help us make sense of something that's happening to us and then help us seek out some help. So I've always liked that phrase. And then the second piece is diagnoses are also snapshots in time. Just because our formal communication should be, this person meets criteria for borderline personality disorder, or this person meets criteria for depression at this time. We don't talk that way because it's clunky, but I like to come back to it so then everybody can know at this point, this problem, this description sort of fits the problem you're experiencing. And hopefully it helps you understand it and helps others understand you and how to help you. If that doesn't help, then we should move on and try and figure something else out. What are your guys' thoughts on diagnosis? Does that fit with your thinking around it as well or different?
Yeah, I get families, individuals who will say, they'll talk about it like a label.
Yeah.
And I try always to demystify that, it's not a label. And to your point, it's a description of a set of challenges that you're going through right now.
Yeah, I often use that clunky phrase because I think it's so important and I can get caught not using it. I like a lot of people will
Oh,
say
me too.
I have BPD, I have ADHD, I have, and then it feels like it's a part of them, right? Like it's like this thing that's permanent. And it's like, well, you meet the criteria for this diagnostic category that a bunch of people sitting around a table thought that these people should be called this because they have these traits or these symptoms. So let's hold on because actually these labels actually change over time. And like we were talking off air, the DSM-3, before earlier than the DSM-3, you couldn't get diagnosed with BPD as an adolescent. And then it changed because the research changed. And so I always hold that bit of caution around putting too much weight on something. But I also think, these categories can help us predict how people are going to respond in certain situations and the challenges they might have moving forward in their life. So with any personality disorder for the general listener, and you guys can correct me, but one of the things that it's a long-standing challenge with interpersonal relationships, right? Like with relationships that have been challenging. And then you have different personality disorders within that, but that might give you a clue to go like, oh, hold on. This isn't just a one-off fight with a friend that I had. This is kind of a pattern in my relationships.
Yeah.
So
And it's not necessarily having a cure where we think, you go to your doctor's office, you get antibiotics for 7 days, and then you're going to be fine after that. This is something that I often describe to people as it's got to be actively managed. You're going to have ebbs and flows along the way. You're going to have ups and downs. During periods of time, you're going to feel great. And other periods of time, something may happen that sort of just creates a challenge that now we have to problem solve, that we have to use what we learned to
Yeah,
cope and manage to get through that snapshot in time.
absolutely. And I think for a big part, a benefit of if someone meets the criteria for the diagnosis, let's say 15, 16, which can happen. And like in our clinics, as I mentioned, 10% of our young people will probably meet those criteria, have that diagnosis. The benefit of it, it allows them to to go and learn about it and us to help teach about it. And so there's a couple of common terms or sort of analogies. One from emotion focused therapy is this idea of a super feeler.
Hmm.
And I like that because it's not a diagnostic term, but it really captures this well. And I can sort of say, like, I wonder if you might be a super feeler. Have you ever heard of that term? No. Okay. Well, let me tell you about it. And super feelers, you know, they feel emotions really strong, way stronger than everybody else. And so, if an analogy is most people have 7 layers of skin. And so, if I have 7 layers of skin on my arm and I'm in a group of people and somebody brushes up against me, gets into my space, I'm sort of like, oh, hey, you step back. You're in my bubble. Doesn't overwhelm me, doesn't dysregulate me a ton because I've got those 7 layers. But let's say I've only got 2 layers of skin and I don't know that that's different than everybody else. And they don't know either. Somebody brushes me up against me in a group and I'm like, get the bleepity bleep away from me. What the heck are you doing? And my reaction is a 10 out of 10. And they now get caught off guard saying, whoa, what's the big deal? But we didn't realize that person only has 2 layers of skin. They feel it a lot more. So a 3 out of 10 for most people might be a 9 or a 10 out of 10 for somebody who's been diagnosed with borderline personality disorder. That idea of super feeler. And then they also stay at that level of distress longer than other people. So, if I get really sad and upset or angry as someone who doesn't fit that description, a couple hours, I'm going to calm down and I'm going to get my lid back on. I'm going to be mentalizing again. Somebody been diagnosed with BPD, it might take a day. And people don't realize, they may not realize they're still hovering up there. And, the slightest thing can now set them off. So this idea of a super feeler, that's a concept that I use in sessions that I find helpful for kids and young people. And then there's another approach that sort of is a cousin of mentalization, I think, which is good psychiatric management. That's a newer thing. They have this analogy and they sort of say, you know what? You are actually a Ferrari driving around in a world designed for minivans. And so what's the difference? Well, minivans are quite practical. They get you where you need to go. They accelerate at a steady pace. They turn well, they handle well in winter. Ferraris, you just touch the gas pedal and you're all of a sudden at 60 miles an hour. And it doesn't steer well on ice, but man, if it's on a racetrack, you're off to the. So nobody, if you were born a Ferrari, nobody taught your parents how to raise a Ferrari because they thought they had a minivan and you don't have the right manual. So we got to learn how to drive this Ferrari. And that's a nice non-stigmatizing description for me, both super feeler and Ferraris, right?
How
That's
about this?
amazing.
How about the Ferrari engine in a minivan? So no one knows it's a Ferrari engine.
The inside a minivan.
The parents don't know. The classmates don't know.
That's right. And it crashes a lot because it takes the corners way too fast. Yeah.
It's a great analogy though, right? Because you look at the person and you're like, hey, that person looks pretty quote unquote normal to me, but they have no clue that you've got that Ferrari engine
There's a
underneath the hood
400
there. And
horsepower engine in
yeah,
there. Nobody knows about it. Yeah, that's a
that's
nice
right.
adjustment, Dave. I like it. I like
Nice,
it.
nice. So, Mark, one of the things I'm hearing here, and I think it just resonates throughout most people's lives, is that there's a lot of like relational stuff going on, the way we relate to other people, right? And BPD is a lot of literature talks about how, to your point about mentalization, is like you're trying to understand what the other person is thinking or feeling, right? And there's a lot of perhaps, I don't know if this is the right way to describe it, and correct me if I'm wrong, but perhaps misinterpretation or overinterpretation, and hence like those relationships and the attachments get sort of out of sync.
Yeah, that's a great point. And I think Dave's example really touched on that when he's got a client who's sort of saying, well, you must not want to see me, right? That's a misread. And so clients like that, they might be getting dysregulated in session. They might be really paying a lot of attention to Dave's, little micro gestures. If he looks away, he looks at the clock, he yawns because he's tired. But then we make a quick assumption about, oh, he's bored. He must really hate working with me. So it is a misread, if you will. And they're more inclined to put the wrong thought bubbles up for Dave. Or they might pick up on something that Dave does seem they're super feelers, so they sometimes pick up on feelings that we as therapists have that we may not realize we're actually showing, right? Because we might have had a bad day. And, the vibe might be different today. I could be frustrated, but we don't know for sure. So it's sitting down and then unpacking that stuff in a therapeutic way, in a safe way, because a lot of folks with BPD haven't had that opportunity to really just unpack it and feel comfortable and safe doing it. And it takes a while to get to that point.
Yeah, and at least from my understanding, one of the hallmarks of this personality disorder is that this fear of abandonment, like that they will
Yeah,
be left, that the other people are gonna, not care for them, right? So
yeah,
you combine that with the super feeler and
that's
this
right.
terror of being abandoned, that can be triggered at, pretty unsuspecting ways, right? Like someone looking away, or someone being 5 minutes late for an appointment. And then it's like, they don't want to meet with me. They don't love me anymore. They don't care about me. And all of a sudden, right? So at least that's been my, because I'll say this, in the literature, in the trainings that I've had, there have been people that have said like, stay away from BPD because it is too hard. Like these people will burn you out, right? They will,
Yeah,
this is a challenging population. And so we need to steer clear of them as much as you can. But then I'm like, my experience working with these people is that they are struggling just like anyone else. And
that's
then
right.
actually people steering clear of them reinforce this idea
Yeah.
that they will be abandoned and avoided and ignored. And it's like, oh my gosh, we just have this so wrong because it
Yeah.
actually is a feedback loop that is increasing the suffering.
And we have a lot of work to do as professionals to get better at supporting folks diagnosed with BPD. And I have heard some very disrespectful things said about this group of clients, and I really don't like it. And I'm happy that we are starting to get better education so we can help educate clients and families, and we can educate each other. We're learning more and more about it, and I think we're getting better, but there's still a lot of work to do. So to have people, we need to have a lot of compassion.
I think going back to your point about that super feeler too, Mark, in my experience working with individuals with borderline personality disorder, there's often that push and pull, almost with everybody around them. Whether I remember at the school board coming across teenagers who were early diagnosed, but even with their teachers and parents, caregivers, friends, there's this, to what Dave was saying before, there's this hypersensitivity or that super feeler where it's like, oh, you're
Yeah,
5 minutes late, you must not want to work with me. But also like when relationships get intense, it's like they want you, they just want to hold you and hug you the entire time.
Right.
And then at the
Right.
same time, the sensitivity comes in. It's like, oh, now I'm pushing you away because you said this one thing, and I'm going to
Yeah.
just push you away, and I'm going to tell you how much I hate you. And then all of that becomes so overwhelming. And then now comes the piece around self-harm. Like it's so uncomfortable.
Yeah.
To your analogy about the 7 layers of skin, now it's like they have scratched the surface and now it's bleeding. Right. And that leads to those thoughts around suicide. I'm wondering if you could talk about, your again, your work around this and how you've come to work with individuals who get to that point.
Yes, but I want to say a couple of other things just about BPD,
Sure.
specifically, Andrew, that
Yep.
one of the reasons with it, or one of the things about the diagnosis is getting that diagnosis. It is, as I said, it's not forever. And we actually have good research now that the course of this disorder, things improve. Symptoms peak around 15 to 16 years old, between 14 and 16, I think. And that was eye-opening for me about 3, 4 years ago when I came across that, where it's like, okay, so when I'm working with this young person, they might be at the most sort of extreme position with this disorder. And then because I don't work with people with them, I don't see them after they turn 18, we don't see what happens afterwards. Well, what the research says is that in about 60% in about 4 years will be in remission. That means they won't meet the criteria for the disorder anymore. We distinguish between remission, which is I don't meet the full criteria, and recovery, which is, hey, I'm I'm emotionally functioning well and I'm having a job, and that's more 40 to 60% like over 10 years. But those numbers surprised me when I heard about them, and they really helped me feel optimistic to sort of, I can tell families things usually get better, especially when you're getting some treatment early on. And I think a lot of us as professionals had assumptions that because we call this a personality disorder, it's a forever thing. And it's not. It doesn't have to be. And we don't have to change our personality per se. We have to focus on the symptoms of this personality disorder, and those can change. So I just want to emphasize that for anybody listening, that this can be a hopeful thing. It does not have to be a life sentence, and things typically get better. Yeah. Okay. And we also don't need to blame anybody about it, because parents get blamed, young people get
Yes.
blamed, therapists often start blaming themselves, and then they, well, I must not. There's genetics, there's environmental stuff. It's a big stew that leads to these kinds of things. So we just got to focus on what will help. Okay. Now, there. What am I supposed to talk about now?
No, I'll piggyback off of that too. I think, with any personality disorder, by definition, it tends to be fairly stable, but it is not permanent, and these things do change. And so, in some ways, the label will give us an idea of how someone might respond typically, but then we're also helping them respond differently, right? And
Yeah.
so the
Yeah.
the book that I was reading to prepare for this was called something about like stop walking on eggshells, right?
Oh, yeah.
And
Yeah.
that's a very popular
Yeah.
kind of,
Mm-hmm.
right? And that's how it can feel for the outsider, right? That isn't the super feeler, that isn't kind of riding that same roller coaster of emotion, right? And then how do we respond in a way that helps the individual who's the super feeler? And then, so like, I know the work that you're doing, you're not only working with the adolescent, you're working with the families too, right? The
Right.
parents.
Yeah. We need parents. We need their
Yeah.
help.
Yeah.
Yeah. Yeah.
So again, I maybe going back to Andrew's question about really a challenge with this population is when they are dysregulated, when they are emotionally overwhelmed,
That's
it
right.
can lead to, they are at higher risk of self-harm, self-injury,
Yes.
suicide, and that is
Yes.
very scary for people around them that are trying to support and love them.
And this is why I think to clinicians or like you said, Mark, like this population gets a bad rap because people will be like, stay away because they're perhaps, at least in the literature, there's a higher risk of self-harm and suicidal ideation.
Yeah, there is. And we want to know. And actually, if if kids are talking about it with us, that's a good thing. It's not a great thing that they have these thoughts, but it's much better that they're talking about them with us than not talking about them, because that's when I get more worried. If a young person is not talking about them or, keeping everything to themselves bottled up. So for therapists, for parents, we do want to know, but it's really hard because it scares the, bleep out of us, especially if you're a parent who's never had that conversation about this topic. It's really upsetting.
Mhm.
And, the first piece of advice is we want to manage our own feelings. We want to focus on our kids' feelings and thoughts and trying to understand this. In order to do that, you need to manage your own feelings. So we've actually come up with some do's and don'ts in one of our handouts that we can give to parents and caregivers about. The first thing you want to do is listen, and listen as much as you can and be curious and validate, actively listen. The don'ts are, don't focus on how this makes you feel right now. And that's hard because it probably comes at the absolute worst time and it catches you off guard. And, it's really upsetting and scary to have your teen talk about this. And so we want to manage our own reactions as best as we can. And we also don't want to fix, right?
Mhm.
That's all of our adult reflexes go into, well, if you're worried about that test, you should just study. And if you
Yeah.
stop playing video games and being on Instagram, you would, not the time for it. I have a colleague that sort of says we want to sort of loosen some of those expectations, lessen them at that time.
Yeah.
And so we want to hear about it. We want to manage our own. We want to take it seriously as well, right?
Yeah.
Most families do, but sometimes families are really burnt out,
Yes.
and parents and caregivers can sort of say they're just doing this for attention. And
Yes.
in that case, we got to work with those parents and caregivers and
Yeah.
figuring out what's getting in their way, because
Yeah.
they're really stressed too.
I always tell parents and caregivers in those moments, we need to connect. We need to make every effort to connect and
Yeah,
bond. Because when
that's a
you
great
say, "Oh,
point.
just get off Instagram, just go study," that is extremely invalidating. And in those moments, just listening, nodding your head, giving a hug, that's connection. And that is so important in those moments.
Yeah, yeah, well put.
I agree. And I think, with this population, it can be hard to connect at times. Like one of the features around all or nothing thinking. And so you might hear things like, you never helped me, right? Or you always do this. And so you're trying to connect, and then you're getting accused of these really terrible things. And like as a parent, to hear that you've never helped me, right? And this is possibly an adult child that you have, spent many
Right.
years giving a lot of your time and energy and money to, and then to hear that and you're saying like, don't react to that. Of course, we shouldn't react to that, but naturally, as human beings, we can
Yeah,
have some pretty poor responses to those statements at times. And to be able to, again, I think to be able to be prepared for it, right? And to be like, oh, they're upset, right? I don't need
right.
to.
Oh, Dave, great point. That's poor and valid responses, because and it's like our loved ones know where our buttons are, and when things are heightened, they take a sledgehammer to that button, and it's like, oh, sometimes I feel really bad what I ask parents to do, because I and you know what? We just got to get it right one third of the time. That's what they talk about. We don't have to be perfect. We're just doing our best, and we can always recover. We can go back and say, hey, I didn't do that the way I wanted to. Can we try over?
I think, Mark, what was really important that you said there too, though, is take it seriously,
Yes.
right? Take it seriously. Because what you said before, I've heard it as well. Parents will say, "Oh, it won't happen. We're going to be fine." It's like, have we actually taken it seriously? Have we actually talked about what that would mean?
Yeah. And when it happens, get them in to talk to somebody. Remember I think it's the 988 line for the suicide distress line that we can call. There's Kids Help Phone. There's going into a walk-in clinic, taking it seriously. And one for clinicians and parents, the two things that there's, well, three things that I cue in on when we're having a discussion around suicide: pain and hopelessness. When someone is considering suicide, it's usually because they're having an overwhelming amount of pain that is dwarfing any connection they have. Same thing with hopelessness. I'm in this pain. I don't think it's ever going to get better. And suicide is a solution to that problem. It's a very poor solution that we don't want to have happen. But young people will view that this would end my pain. And we want them connected as much as we can. And when I'm talking with a young person, and the other thing I was thinking about too, when you were talking, Dave, is we tell parents to connect with their kids, but their kids might be shutting the door, locking the door, saying, I don't want to talk to you, leave me alone. And that's really hard. So parents are trying to connect, but they're getting shut down. So it's really tricky. And sometimes finding one of us to meet with that young person. And what I will ask about if someone's not talking, I will say what I've learned is that, young people who are having thoughts of suicide often are feeling a lot of pain and or a lot of hopelessness. And I was wondering if that's happening for you. And you will almost always get them nodding. And that might open the door a smidge where they start saying, this is what caused me pain. And so then we're not trying to fix it. We're just trying to listen to it. And we're saying, thank you for telling me that. But I find that pain and hopelessness, those two things open some doors and help me think about it when somebody's doing those things.
I have about 10 thoughts going through my head. So now I got to pick one and conscious of time too.
Yeah.
Maybe, and this might be a really hard one, and maybe you can't even speak to this today, and we'll have to have another episode on it. But, one of the strategies is having good boundaries and having clear boundaries and letting people know kind of what to expect with what happens. But with suicide, with self-harm, it can be very scary. So if you leave me, I'm going to cut, or if you leave me, I'm going to kill myself. And then it's like, oh, no, I can't, right? Naturally, you have to take it seriously. But if this happens repeatedly, like, how are you supporting parents to maintain that connection and also have kind of healthy boundaries for themselves to be able to, go to work if they need to go to work in the morning, or like this is to me one of the most difficult areas when you genuinely care about the person, right? And you do not want them to suffer or be in pain, and yet they're saying they will do something to themselves if you don't, or if this happens.
Yeah, that's a hard question, Dave. And when things are at that general level, I find it hard to answer. My instinct is always to go in. It sort of depends on the context and what's going on. But ultimately, I guess I would, I don't have a quick answer for you. That would be that I know validation is really trying to understand what this kid's afraid of and what they're struggling with. And yeah, Andrew, you have thoughts?
I think it is a very tough question to answer, because in those situations I work very contextually. What's happening for that person in that particular moment. And so I'm just even thinking, as an example, for this week, I had a client who was very, very distressed. And it was a tough case because this person was so upset with the parents, and everything was directed towards parents. And so in my role, like, as I understood it, I've seen this person for quite a while now, and this was as distressed as I've ever seen them. But in my role in that particular situation, it was like, okay, how do I stay unbiased? How do I continue validating, but not taking sides per se? And having them, I think, going to this mentalization, like both of you were saying, to be a good therapist, you're probably mentalizing in the moment. And I think that's what I was doing in that moment, is like, how do I stay as a third party, but yet I'm bringing a sense of validation, perhaps some reason and emotional stability into that particular situation.
Turn down the temperature.
Yeah. Turning down that temperature, take you a notch down, finding some sort of gray area that we can bring parents and the teenager in together, helping the person not see the situation so black and white. It's not, I either don't exist or I exist in the happiest place that I can be, right? Do we have to be in that happiest place? And do I have to also, if not, does that mean I cannot exist whatsoever? Right. So it's like trying to marry the two sides together. And I'm not gonna lie, I was exhausted after that session. And I think that's the piece around mentalization. If you're seeing, I don't know, 5, 6 clients a day and you are staying in that mentalized state, it's exhausting.
Right, right. No, I appreciate those thoughts, Andrew, and it gave me some time to think because with that example, Dave, I think it really depends on maybe that person shouldn't be left alone, but maybe they need to work through something with you and their parents. And that's the content of a whole session as Andrew's going into. This is where we need to be assessing where they're at with their level of suicidality, with their self-harm, and what parents are concerned about. Because, yeah, there's more things around self-harm. Self-harm is not the same as suicide. And people use self-harm to cope. And that requires some conversations with parents as well as these things aren't going to go away right away. And young people are trying to figure out how to manage these feelings, these super feelers, these Ferraris. And that's a short-term solution that has helped them. We want to try and find something that's better, but still helpful. And I mean, I know we're running out of time. There was one thing, probably if one thing I want to emphasize, doing safety planning with a professional if you have concerns. So getting your young person assessed and speaking to someone who can help you figure out where things are at. And we as professionals don't know all of this either. We can't predict who's going to attempt suicide, but we have some ideas and some questions we can ask. We can get a better understanding of it. And then you can go through a safety planning process with them, which is also challenging. But I've been around enough, unfortunately, attempts by young people that when we do safety planning with parents, I like to emphasize medications because a lot of young people will overdose, or the ones who do attempt will use pills and medication. And so I like to emphasize every medication in the house needs to be secured and everyone's medication. So when I say every, that means Tylenol, ibuprofen, which we often don't think about, that can cause a lot of damage, and also everyone's, because sometimes families will just lock up the young person's medications, and grandpa's medications his heart medication is in the medicine cabinet. And so we need every and everyone's medication. That's something that I always emphasize when you need to safety plan. But yeah, anything else? I'm mindful we're over time, aren't we?
You know what, Mark? I think regardless of time, like this is such an important discussion that, throughout our podcast episodes, we haven't touched on this yet. And I think that final point that you put out there in terms of safety is so important. And it's a reminder to everybody that what we may not see as a threat can easily be a threat to one's health. So thank you for bringing that up. And we usually do a little bit of a conclusion, Dave and I, and you can join in, Mark, if you'd like.
Yeah.
But we often do a takeaway from today's episode. And to me, this was a really eye-opening discussion about mentalization, about working with youth with BPD, because like we've emphasized already, so many people try to stay away from it because of all the stereotypes perhaps that we hear. But you bring a really hopeful perspective, and I really appreciated that. And for
Thank you.
any clinicians out there listening, I hope that's what we get away from this episode, is that we can work with individuals with borderline personality disorder, that it's more about the management and helping them see the hope that's there, and that not everything is so black and white. We can see the gray.
Yeah. Yeah. Thanks, Andrew. I want to do a shout out to any of the clients that I've worked with BPD, because I've learned a ton from them, and I have good memories. And so yeah, it is pretty cool to I got hope around it. And yeah, this has been a fun discussion.
Yeah, I feel like this is just getting started. So I wish we had another hour because
Very much so.
yeah. Oh, and I feel for all the people out there, the parents, the people diagnosed with BPD, right? Like this can be really challenging. And I love that the narrative is changing, that we're approaching this differently. And I've even in a bit of my preparations for today was coming across like support groups and online resources for people diagnosed with BPD and being able to connect and not just be isolated with it. I think some of these diagnoses are actually a label that isolate people, isolate families. And so I love hearing you talk about this, Mark, because I feel like this is a breath of fresh air for this diagnosis that like, hey, it's hopeful. We can work at this. Like you've been doing this for a long time, right? Like, and
Good.
you don't look burnt out. You don't look like, yeah.
And I'm gonna add to that. I've known Mark for a while, and the clients who get to work with Mark, I think, are very lucky because he is a very energetic, very positive individual who brings a lot of energy to sessions. So I think
Ah,
that is what the population, needs. They can't walk into a session and, have a therapist who is afraid or pessimistic or doesn't have that ray of hope, right? So I think Mark, they're very lucky to have you there.
oh, thank you, Andrew. And yeah, I am very pleased to be associated, even just a little bit, with the work you're doing. If anything we did had any influence on that, I'm pretty happy about that. So thank you for that kind compliment.
I'll add more, Andrew, because I think energetic is one thing, but compassionate. I think your
Yes.
compassion and I think it's really nice to hear about mentalization because I think I'm more familiar with the skills of DBT to help individuals, but just
Yeah.
Yeah,
really sitting across from someone, trying to be curious about what is going on for them and sharing what's going on for you on a real human level, right? I think
yeah,
that to me is what I'm taking away from this, that is an
yeah, great.
evidence-based treatment, that there is
Yes.
support to say that we can
Yeah.
do this.
This works. This works.
And we're not just chatting with someone, right? There's some help that is measurable in the research to say this approach can be beneficial. Yeah, so I
Nice,
love
nice.
that. I think I
Okay.
need to do some training in that area.
Hey, talk to
Yeah,
me.
me
Yeah,
too.
absolutely. Well, thank
Well,
you
thank
guys.
you. No, thank you. Thank you for taking your time and volunteering your time and your knowledge. This was amazing. And so many, I feel like we've only touched the surface of so many different areas, and we're gonna have to like do a deep dive at some point into mentalization, BPD, and suicide as well, and look into all those three areas. So thank you again, Mark. And if you're enjoying this podcast, this episode, please follow, like, send us comments, questions. We'll be happy to respond. So, everyone, take good care.
Take care.